So imagine you're suffering from severe chronic pelvic pain, like the kind that becomes so debilitating, you finally just agree to undergo a laparoscopy,
Mm.
to find the root cause.
Right. Which is a pretty major step for anyone to take.
Exactly, it's surgery. But you wake up from anesthesia, and the surgeon tells you that your reproductive organs are perfectly healthy. There's no endometriosis, no cysts, basically no visible pathology at all.
Which, I mean, it sounds like good news on the surface.
Yeah, it sounds great,
Yeah.
but it leaves you entirely without an answer. You're just trapped in the exact same amount of pain. And according to the clinical data we're looking at today, this exact scenario happens to a staggering 77% of patients who present with unexplained pelvic pain.
Wow. 77%.
Right. Their organs are perfectly fine, but their biomechanics are actively tearing themselves apart.
Yeah, and it is just one of the most frustrating diagnostic dead ends in modern medicine today. Because we have this natural tendency to look for pain exactly where we feel it.
Right. My knee hurts. Check the knee.
Exactly. But when you step into the really complex world of human biomechanics, that localized approach completely falls apart. Like, the source of the pain and the actual symptom, they're often located in entirely different zip codes of the body.
Which is exactly why we are doing this custom-tailored deep dive for you today. We're looking at a stack of really specific sources you provided us, including research from the Journal of Medicine, the Journal of Physical Therapy Science, and clinical guidelines from the British Society of Urogynecology.
Some really heavy-hitting medical literature in there.
Oh, for sure. And our mission today is to trace this hidden, incredibly precise mechanical chain reaction. We're going to explore how a seemingly harmless issue, like, one leg being just a fraction longer than the other, how that can cascade upward through the body and result in unilateral painful sex, which is clinically known as dyspareunia.
In this topic, it really demands that we fundamentally change how we view our anatomy. I mean, a lot of us might notice that we have, like, a slight slouch or maybe one pant leg always seems to drag on the floor.
Yeah, while the other one sits perfectly at the ankle.
Right, and most people just brush that off as a weird postural quirk. They would never suspect that the way their feet hit the ground is actually dictating the muscle tension in their pelvis.
Okay, so let's unpack this, because it helps to have a visual. Think of the human pelvis as the concrete foundation of a house.
That's a good way to look at it.
Right, so if that foundation is poured even slightly unevenly, the stress doesn't just stay in the basement. It travels upward and inward. The door frames get crooked, the windows won't shut properly, and the floorboards, which in our anatomical model is the pelvic floor, those floorboards are going to warp and splinter and just groan under that constant uneven weight distribution.
Yeah, and that is the exact mechanical reality of a leg length discrepancy, or LLD, as we'll call it.
Got it.
And from a clinical standpoint, LLD breaks down into two very distinct categories, which, frankly, dictate entirely different treatment paths. So the first one is structural LLD. This is a literal bone-deep difference.
Like the actual bone is longer.
Right. Exactly, whether it's due to genetics or maybe a childhood fracture that altered the growth plate or even joint replacement. The actual femur or tibia on one side of your body is measurably longer than the other.
Okay, so structural is fixed anatomy. That makes sense. But the second category in the research is functional leg length discrepancy. And this seems infinitely more complex because the bones are actually perfectly symmetrical, right?
Oh, yeah, completely symmetrical. In a functional LLD, if we took an X-ray, it would show that your left and right femurs are identical in length, but one leg is functioning as if it's shorter.
Because of the muscles.
Because of severe soft tissue compensations, yeah. This usually originates in the really heavy lifting muscles that connect your lumbar spine and rib cage down to your pelvis.
Okay, so like the quadratus lumborum.
Yes. Perfect example. The QL anchors your lowest rib to your iliac crest. So think about it. If you spend 8 hours a day sitting unevenly at a desk, or you're constantly shifting your weight onto one side, that massive muscle can become chronically shortened.
It just tightens up and stays that way.
It essentially seizes up, and it physically pulls that side of your pelvis upward toward your ribs, so the leg attached to that side is hoisted up with it, making it act shorter, even though the bone length is fine.
Wow. Okay, so if a patient walks into a clinic with this kind of postural imbalance, how do clinicians accurately differentiate between a structural bone difference and a functional muscle contracture. I mean, if you get that diagnosis wrong, the treatment is going to be completely useless.
It's going to be worse than useless, honestly. It requires some very precise kinesiology. Now, a standard scan can confirm a structural discrepancy just by measuring the bones. But physical therapists, they typically identify functional LLD through dynamic movement.
Like a gait analysis.
Exactly, gait analysis. They watch the kinematics of your center of mass while you walk. If you have a structural difference, your center of mass will noticeably drop every single time you step on the shorter leg.
Oh, because the leg is literally shorter, so you drop.
Right. But with a functional difference, the soft tissues have already adapted to the imbalance. They've altered your pelvic rotation entirely. So you don't see that same dramatic unilateral drop in the center of mass.
That is so interesting. And the sources also detail this thing called the supine to sit test, which I found fascinating mechanically.
Yeah, that's a classic clinical test.
So basically, the therapist has you lie flat on your back, and they check the alignment of your medial your inner ankle bones, right?
Right.
Then they just have you sit up straight.
Right.
And if the alignment of your ankles visibly shifts as you move from lying down to sitting up, that indicates that the innominate bone of the pelvis is rotated. Like the actual movement of sitting up forces that twisted pelvic bone to express its asymmetry all the way down the kinetic chain to your ankles.
Precisely. It exposes the rotation. And this leads to what clinicians call a lateral pelvic tilt, or pelvic obliquity.
Pelvic obliquity.
Yeah. To borrow an analogy from the literature, you can imagine the pelvis as a large bowl of water. In a lateral tilt, the bowl is tipped, and the water is just constantly spilling out over one side. The entire load-bearing geometry of the human body is totally thrown off its center of gravity.
Okay, I do want to push back on the pathology of this for just a second, though, just to avoid over-medicalizing normal human variation.
Sure, fair enough.
Because the sources explicitly note that in a healthy, neutral stance, the pelvis naturally tilts forward about 10 degrees in females and 5 degrees in males.
Right, an anterior tilt is normal.
Exactly. Furthermore, absolute structural symmetry is incredibly rare in nature. Nobody is perfectly symmetrical. So at what exact point does normal become a medical problem? How do clinicians differentiate between a harmless natural asymmetry and a pathological lateral tilt that is actually destroying the foundation?
If we connect this to the bigger picture, your skepticism is highly warranted. Clinical guidelines are very clear that minor discrepancies, typically anything under 1 centimeter, are practically universal. And they are usually completely asymptomatic. Because the human body is a brilliant compensator, right? It micro-adjusts without you ever even knowing.
So when does it break down?
The pathology begins when that discrepancy exceeds, say, 1.5 to 2 centimeters. Or, crucially, when a functional holding pattern is sustained for years. At that threshold, those little micro-adjustments fail. The body has to actively recruit major muscle groups to fight gravity, literally just to keep your eyes level with the horizon.
Oh, wow. So it forces the body to lock a bad compensatory posture into place permanently.
Exactly. And that locking in physically alters the curvature of the spine. It usually exaggerates the lumbar lordosis or the curve in your lower back. It unevenly loads the facet joints of the spine, and it alters the trajectory of literally every step you take.
But most importantly for our deep dive today, it applies this devastating torque to the soft tissue structures attached to the bottom of that tilted bowl.
Yes, the pelvic floor.
Right. And looking at the anatomical diagrams in the sources, the pelvic floor is not just some passive membrane. It is a highly dynamic, vital muscular sling.
It really is.
We are talking about an intricate web of muscles, like the levator ani, the obturator internus, the piriformis, and this sling, it reflexively controls your bladder and bowel function, while physically bearing the weight of your internal organs.
It's an architectural marvel. But its integrity relies entirely on the pelvis providing a level, symmetrical anchor.
Which, if the bowl is spilling water, it isn't level anymore.
Exactly. When the pelvis tilts laterally, it triggers a mechanical phenomenon that the researcher Carol Lewitt described as contralateral asymmetry, because a lateral tilt doesn't just mean one side of the pelvis drops straight down.
Right, it's not a 2D movement.
No, the pelvis is a ring. So when it tilts laterally, it also rotates asymmetrically in multiple planes. One hip bone rotates anteriorly and inferiorly so, forward and down, while the opposite side rotates posteriorly and superiorly backward and up.
Okay, here's where it gets really interesting mechanically. If we map that out using like a suspension bridge analogy.
Let's hear it.
So the pelvis serves as the main towers of the bridge, and the pelvic floor muscles are the suspension cables. Because of that multiplanar rotation you just described, the main towers are suddenly leaning and twisting away from each other.
Yeah, they're torquing.
Right, torquing. So suspension cables on one side are going to be pulled dangerously taut, stretched to their absolute physical limit, while the cables on the other side are given way too much slack.
That is a perfect visualization of the internal environment. Because those muscles on the stretch side, they are suddenly stripped of their mechanical advantage. They are forced to basically fight for their lives to stabilize the sacroiliac joint and the symphysis pubis.
Just to hold the pelvis together.
Yes. To prevent the pelvis from shearing apart under that uneven load, those specific pelvic floor muscles go into a state of chronic spasm. They clench, and they simply do not let go. Clinically, we call this hypertonicity.
Which brings us back to that staggering statistic from the laparoscopy studies at the very beginning of the deep dive. This is why 77% of patients with unexplained pelvic pain had completely healthy organs, but showed severe dysfunction and hypertonicity in their levator antemuscles compared to just 4% of pain-free controls.
It's all mechanical.
The pain is agonizingly real, but it's essentially the suspension cables of the pelvis snapping under the tension of a crooked foundation.
And this hypertonicity creates highly localized, exquisite tenderness that can be isolated during a physical exam. A skilled pelvic floor physical therapist can identify this through single-digit palpation.
Like pressing on specific muscles internally.
Exactly. Take the obturator internus, for example. The therapist will often place the patient in the lithotomy position, so lying back with knees bent and apart. The examiner will palpate that internal muscle while asking the patient to push their knee outward against the examiner's hand.
Oh, so they're forcing the muscle to work while pressing on it.
Right. Engaging that muscle against resistance forces an already exhausted, spasming muscle to fire, which immediately reproduces that shark-specific pelvic pain the patient has been experiencing.
So if we establish that these muscles are acting like rigid, burning cables, it logically dictates what happens when you introduce dynamic physical friction to that specific area. Which brings us to the profound impact this mechanical chain reaction has on intimacy, specifically dyspareunia.
Yeah. Dyspareunia, or painful sexual intercourse, is so often viewed solely through a gynecological or a psychological lens, but in this context, it is a direct mechanical consequence of that pelvic obliquity we've been talking about.
And the clinical descriptions provided by patients in the research are incredibly visceral. When penetration occurs against a hypertonic pelvic floor, they don't just describe it as, generalized discomfort. They describe it as literally hitting a physical wall.
Yeah, it's a hard stop.
Right. It induces severe burning, stabbing, and deep aching sensations.
And this mechanical pathway perfectly explains the unilateral nature of the pain, which is really the key focus of our deep dive today. A lot of patients wonder, why is it excruciating on one side but totally fine on the other?
Right. Why just one side?
Because the lateral pelvic tilt forces the pelvic ring into that asymmetrical rotation we talked about. It is usually only one side of the pelvic floor that gets locked into that massive stabilizing spasm. Therefore, the tissue friction and the nerve compression during intimacy are highly localized to that specific overactive side of the vaginal wall.
That makes perfect sense. The cables on one side are tight, so that's where it hurts. But the sources also highlight that this mechanical friction immediately triggers a severe neurological cascade. We're talking about the viscerosomatic reflex.
Yes. Because chronic pain is never just physical, right? It rewires your nervous system. If a patient experiences a sharp stabbing pain every single time they attempt intimacy, the central nervous system learns to anticipate that trauma.
It's bracing for it.
Exactly. The moment intimacy is even initiated, the brain signals the sympathetic nervous system, which is our fight-or-flight response. This triggers the viscerosomatic reflex, where emotional anxiety is directly translated into physical muscle guarding.
So the anxiety literally commands the pelvic floor muscles to brace for impact.
Yes.
Which means those muscles, which are already in a hypertonic spasm because of the tilted pelvis, clench even tighter. This guarantees that penetration will cause extreme pain, which then validates the brain's anxiety, ensuring an even stronger viscerosomatic reflex the next time.
It's awful.
Yeah.
It is a completely self-sustaining loop of physical tension and neurological panic.
And this leads me to a major problem with how pelvic pain is often discussed in mainstream culture. The ubiquitous advice for literally any pelvic issue is always, do your Kegels, strengthen your pelvic floor.
Oh, don't even get me started.
But mechanically, a Kegel is a concentric contraction, right? You're squeezing. If a patient's pelvic floor is already locked in an ischemic spasm, meaning it's deprived of oxygen because it's been clenched for months just to hold the tilted pelvis together, wouldn't doing Kegels trap more lactic acid, increase the hypertonicity, and make the dyspareunia significantly worse?
What's fascinating here is that you have precisely diagnosed one of the most damaging misconceptions in pelvic physical therapy.
Really? So Kegels are bad here.
Yes, prescribing Kegels for this specific presentation is completely counterproductive. Unilateral dyspareunia stemming from a pelvic tilt is a high tone disorder. The muscles are not weak, they are overworked, rigid, and neurologically locked in the on position.
They're exhausted, not weak.
Exactly. Asking a spasming muscle to contract further will only exacerbate the ischemia and the pain. The clinical objective is never strengthening in these cases. The objective is lengthening and releasing.
So, knowing that this pain isn't a structural failure of the reproductive organs, and it isn't muscular weakness, how do clinicians actually dismantle this chain reaction? What is the mechanical solution to rewiring this high-tone disorder?
Well, the intervention has to be a two-pronged approach. You have to work from the foundation upward. You have to correct the leg length discrepancy first, or the pelvic floor will just keep spasming to protect the imbalance.
Because the bowl is still tilted.
Right. If it's a true structural LLD where the bone is actually shorter, the solution is beautifully simple. It's just a custom shoe insert or a heel lift. Providing that missing height instantly levels the pelvic mole and removes the asymmetrical load from the pelvic floor.
Okay, but if it's a functional LLD, a shoe insert would just validate the bad posture, right? The therapist has to manually unlock the soft tissue.
Exactly. Functional LLD requires targeted manual therapy. Usually, this means focusing on mobilizing restrictions in the thoracolumbar fascia. The physical therapist has to physically release those chronically tight muscles, like the quadratus lumborum and the iliopsoas. They are essentially stretching and manipulating the pelvis back into a neutral, symmetrical alignment.
And once that foundation's leveled out, the suspension cables are still going to be stuck in that defensive posture, right?
Oh yeah, they don't just snap back to normal on their own.
Which brings us to the specific pelvic floor physical therapy, or PFPT, interventions mentioned in the clinical guidelines. And this goes way beyond standard stretching.
It does. It is highly specialized internal and external clinical work. The primary tool they use is myofascial trigger point release.
And mechanically, how does sustained pressure actually force a muscle knot that has been locked for, years to finally let go?
It relies on a physiological mechanism called ischemic compression. Basically, the therapist applies very specific, sustained pressure directly to the hypertonic knot in the pelvic floor. This temporarily cuts off the localized blood flow to that tiny area of muscle tissue.
So they starve it of oxygen on purpose.
Yes. This localized oxygen deprivation forces the muscle fibers to release their chemical grip. And the moment the therapist releases the pressure, a massive rush of fresh, oxygenated blood floods the tissue. This flushes out inflammatory noopeptides like substance P and finally allows the muscle fibers to elongate.
Wow. And there is a clinical study in the stack of sources that perfectly illustrates how effective this is. The researchers utilized a specific transvaginal technique called theomassage on patients suffering from dyspareunia.
The results of that study are fantastic.
They really are. And the protocol was remarkably brief, just 5 minutes of targeted massage once a week for 4 weeks. Yet they recorded highly significant long-term improvements in painful sex, which they verified across standard metrics like the Visual Analog Scale and the McGill Pain Index.
It really proves just how responsive the pelvic floor can be once the correct mechanical intervention is applied to the fascia.
So what does this all mean for the patient? I think a much better way to visualize this therapy is untangling a knotted rope. If you have a tight knot pulling on the ends, which is what Kegels or daily stress do, that only binds the fibers tighter.
Right.
This specialized manual therapy is like gently pushing slack into the knot. It gives the fibers the physical space they need to unbind and lay flat again.
That's a great analogy. This raises an important question, though. How long does the central nervous system take to accept this newly untangled state? Because the muscle memory is deeply, deeply ingrained.
Right. The brain is still bracing for pain.
Exactly. Now, the data shows that mild cases can respond in just 6 to 8 sessions of specialized PT, but that's provided the patient actively participates in neuromuscular re-education.
Meaning they can't just be passive recipients of the massage. They have to rewire the brain-muscle connection themselves.
Exactly. This often involves clinical biofeedback. Patients use sensors to visually see on a screen when their pelvic floor is clenching, which allows them to consciously practice turning the muscle off. But the single most critical at-home component is diaphragmatic breathing.
Belly breathing. But wait, how exactly does expanding your stomach release a muscle all the way down in your pelvis?
Well, the respiratory diaphragm and the pelvic floor diaphragm, they work together like a synchronized piston inside the abdominal cavity. When you take a deep diaphragmatic breath, the respiratory diaphragm pushes downward. This increases intra-abdominal pressure, which mechanically forces the pelvic floor to lengthen and drop down in response.
Oh, so they move together.
Yes. Furthermore, deep, slow breathing stimulates the vagus nerve. And the vagus nerve actively overrides the sympathetic nervous system. It physically forces the brain out of fight or flight mode. That breaks that viscerosomatic reflex we talked about and signals the pelvic floor that it is finally safe to stand down.
That is incredibly empowering. So, to synthesize all of this for you listening today, if you are dealing with unexplained, one-sided pelvic pain or severe discomfort during intimacy, it is absolutely not all in your head.
Not at all.
And the laparoscopy statistics prove it very likely isn't a disease of your organs either. The root cause could trace all the way down to a subtle mechanical discrepancy in how your feet carry your weight and how your pelvis rotates to balance that load. It is a highly complex mechanical problem, but that means it has a highly logical mechanical solution.
It really is a brilliant testament to the deep structural interconnectedness of our anatomy. And, I want to leave you with a final thought to mull over, building on that mind-body connection we just discussed.
Let's hear it.
We've established how a tilted pelvis forces the pelvic floor into spasm, causing dyspareunia. And we know that diaphragmatic breathing is the key to breaking that spasm. But consider the reverse loop, which is heavily implied in the broader biomechanical research. What if poor breathing was actually the genesis of the physical tilt?
Wait, really? Like breathing caused the tilt?
Think about it. Could modern chronic emotional stress, which causes us to live in a state of shallow, rapid chest breathing, be the original trigger? If chronic anxiety fundamentally freezes our diaphragm, could that constant subtle tension in our upper body slowly shift our posture over years?
Oh, wow.
Could our emotional stress be the very thing creating the muscular contractures that lead to a functional leg length discrepancy, which then tilts the pelvis and eventually ruins the pelvic floor? It leaves us to ponder this endless, fascinating two-way street, how our physical foundation dictates our pain and how our mental state might be pouring the concrete.
That is wild. So the next time you notice that one pant leg dragging on the floor,
Yeah.
remember, your foundation is talking to you. It might be time to listen.